Hello, my name is Lee Murphy, and I'm a pediatric cardiac intensive care doctor at Riley Hospital for Children in Indianapolis, Indiana. Thank you for allowing me the opportunity to present at your conference today and talk about cardiac emergencies. Just for the objectives, I tried to break it up into case presentation format, look at a broad categories of congenital heart disease, go over the pathophysiology of these categories, and then look at the management. So let's look at our first case. This is a 9-day-old male infant. These are all real cases. Brought to the pediatrician with eye discharge and diagnosed with conjunctivitis without having any other symptoms. Prior to being discharged, a complete physical exam was done, but the practitioner could not feel femoral pulses. The vital signs are below, with a heart rate that's slightly elevated for the neonate and a respiratory rate of 36. The practitioner did upper and lower extremity blood pressures and got an upper extremity blood pressure of 70/48 with a lower extremity blood pressure that was not able to be attained. Of course, in able to do this in a pediatrician's office and even some ERs, a neonatal blood pressure cuff would need to be available. If they weren't available, we could use things like feeling for femoral pulses or dorsal pedal pulses, capillary refill, number of wet diapers, since your kidneys will be perfused post your systemic ductal-dependent blood flow. So what is the next most important step in the management of this patient? Most likely, if we were in an outpatient setting, I would send them to a hospital. If we were in an inpatient setting, say in an emergency department, I would go ahead and start prostaglandin E1 infusion. So most likely this baby is presenting with a ductal-dependent systemic blood flow problem, and all of these lesions will involve obstruction of the left ventricular outflow tract. So most likely this baby will have critical coarctation of the aorta, but some other lesions in this category are interrupted aortic arch, critical aortic stenosis, and hypoplastic left heart syndrome. The picture here on the right is just a picture of a normal heart. You can see that all 4 chambers are present. Here's an open ductus arteriosus, and because the pressure and resistance in the aorta is higher than your pulmonary pressure and pulmonary vascular resistance, shunting occurs left to right with oxygenated blood flowing into the deoxygenated blood through the ductus. Here in this picture on the right, you can see there's a coarctation of the aorta with the narrowing there and a duct that is also open. You are getting right to left blue blood flowing from right to left from the pulmonary arteries to the aorta to the rest of the body, and it's not completely cut off here, so you're still getting a small amount of oxygenated blood coming through and mixing with the deoxygenated blood from the pulmonary arteries. But if you did pulse oximetry on this baby, if you put a pulse ox on the preductal arm, on the right arm, and you put a pulse ox on either of the lower extremities, you can see that the right arm would probably sat close to 100%, and the lower extremities would sat lower than your upper extremities, probably somewhere in the high 80s. Anytime that you get sudden cardiovascular collapse in a neonate less than 1 month of age, I would consider, is this a ductal-dependent systemic blood flow issue until proven otherwise? And the highest incidence of mortality in these patients is when they are discharged from the newborn nursery without a diagnosis. So a little bit about the pathophysiology of ductal-dependent systemic blood flow lesions. So as the ductus closes, you get a severe increase in the left ventricular afterload, which ultimately leads to decreased stroke volume and decreased cardiac output. The immature myocardium is not equipped to handle this sudden increase in afterload. It does try to compensate by increasing the heart rate to preserve cardiac output, although the response is typically inadequate. The increased afterload also increases your ventricular wall tension, which increases myocardial oxygen demand in the setting of decreased myocardial perfusion pressure and is ultimately a bad combination for the patient. This will lead to a patient that develops pulmonary edema and cardiogenic shock. Now some specific examples of ductal-dependent systemic blood flow. This is the example that our patient had in the first case of the critical coarctation of the aorta. In this case, you'll feel diminished femoral pulses, and there should be a systolic blood pressure gradient if you take your blood pressure on the right upper extremity and the lower extremities of at least 8 millimeters of mercury or greater. You can listen for an ejection murmur. There is occasionally a prominent precordial impulse, and occasionally you'll also have hepatomegaly and a gallop rhythm, depending on how much heart failure the baby is in. On chest x-ray, you can see pulmonary edema, and on the EKG, you may notice right ventricular hypertrophy and left ventricular. However, if you do blood pressures right at birth on this child with critical coarctation, the upper and lower extremity blood pressures will most likely be the same because this duct will be open and supplying enough blood to the lower extremities. By day 5, though, I would expect that the ductus may start narrowing to the point where you are able to detect a difference between your upper and lower blood pressure extremities. There are 2 cases that I can think of, though, in which case you may not see a difference in blood pressure, and one of the reasons is if your LV has very poor function and you are not able to generate that great of a pressure preductal. And the second case would be as if you had an aberrant right subclavian, so your right subclavian came off after your coarctation, then the pressure you measure from that and the pressure you measure in the lower extremities would be the same. Differential cyanosis is often present at birth. We talked about that prior and the reasons why. And then most of these kids will have higher saturation in the upper extremities prior to the duct closing. And any saturation difference greater than or equal to 4% should be considered significant and investigated. These are just some other examples of ductal-dependent systemic blood flow lesions. Here on the left is critical aortic stenosis. You can see that the aortic valve is kind of covered up with just that pinpoint there that you can see a little red blood, oxygenated blood shooting through. And on the right is interrupted aortic arch, where you can see the arch is completely interrupted and you get continuation from the pulmonary arteries to the ductus arteriosus to the transverse and descending aortic arch. In this example, you can clearly see why you would need the ductus to stay open, since the blood coming from the pulmonary arteries to the aorta is not only filling anterograde but retrograde as well, since there's such a little amount of blood flow coming through your aortic valve. This is hypoplastic left heart syndrome. You can see this is the diminutive left ventricle, left atrium, small mitral valve, and because the left ventricle is so small, all the left-sided structures are small. So you can see that this is the aorta, and when you compare it to the pulmonary artery, very small in size, too small to carry an adequate output to supply the body, and you will need the ductus arteriosus to remain open to supply the cardiac output. So management of ductal-dependent systemic blood flow, prostaglandin E1 infusion to open up that duct will be the most important. You can start the infusion anywhere from 0.03 to 0.1 mics per kilo per minute. I'd probably start at 0.05. Just realize that the higher dose you get with it, the more likely the patient is to experience apnea with it and may require intubation. But just because the prostaglandin infusion is started, it still may be several hours before perfusion improves. In the meantime, if the baby has advanced cardiogenic shock, the baby may need to be intubated to decrease the metabolic demand on the heart. And then after you're able to get the prostaglandin E1 infusion started and the airway can secure, the baby or the patient's ventricular function will most likely be depressed. So starting an inotrope to help with the depressed function would be my next step. Epinephrine is a great drug for this. I would start somewhere between 0.03 to 0.1. And the reason the higher doses may not be as helpful and potentially harmful is because you'll start to get vasoconstrictive effects on the vascular and actually increase your afterload, which may be more harmful than helpful to the patient. And then we know that babies or neonates are very calcium dependent, so correcting hypocalcemia, I would try to keep the ionized calcium greater than 1.2, and you can either use calcium gluconate or calcium chloride to achieve this. Once your duct begins to open, you can consider a little bit of fluid resuscitation. I would say even maybe starting with 5 mLs per kilo up to 10 mLs per kilo of normal saline over 15 minutes may be beneficial to the patient, but the important thing is to closely monitor during that infusion. And if your heart rate starts to come down, starts to increase instead of come down like we would think, or your blood pressure starts to decrease instead of increase, then stop the infusion. So this is case number 2. This is a 2-month-old male infant that presented to the emergency department with poor feeding, tachypnea, and cool extremities. So a little bit about the past birth history. The kid was born full term via vaginal delivery. It did fine after birth, but then around 5 weeks of age, started to have poor weight gain due to poor feeding. At that time, the pediatrician recommended syringe feeding the baby. You can see the vital signs here. The heart rate is slightly elevated, and the respiratory rate is also elevated for age, but SAT is 97% on room air. The baby is tachypnic, and this is a real case, so there was not much else documented. The patient, so what is the next step in the management of this patient? If I was seeing this patient in the emergency department, and this was not a cardiac lecture, I would say that chest x-ray would be the next most likely step based on the tachypnea and the slight bit of tachycardia. This patient was ultimately admitted to the pediatric ward without much diagnostic evaluation or IV access, with the diagnosis of poor weight gain or failure to thrive. But while on the pediatric floor, began gasping and became cyanotic. The pediatric ICU team was called, and the patient was intubated with a post-intubation chest x-ray that showed cardiomegaly, which I have a picture of next. And also at ABG, arterial blood gas was performed, which showed a pH of 6.9 and quite a low bicarb of 4.5. This is the chest x-ray. You can clearly see that the patient was intubated. Looks like had a left subclavian line put in that ended right there. But the big thing to notice is your lungs show a significant amount of pulmonary edema. Your heart border is quite large. And the liver here, even though this was not abdominal chest film, extends post where you can see it, with this being the 12th rib right there. So just a little bit about cardiomegaly. Really, it's a ratio of the cardiac silhouette to the thoracic cavity, and here are measurements of where you can take it from the heart borders to the thoracic cavity. If it's greater than 0.6, then it should raise a red flag, and investigation should occur. So what's the differential on this patient's list? It's a broad list that includes respiratory disease, sepsis, acquired heart disease, congenital heart disease, arteriovenous malformations, and the list could go on. But since this is primarily a cardiac lecture talk, we'll talk about left to right shunts. So some examples of left to right shunts are ASDs, VSDs, and atrioventricular canal defects. This is a picture of an atrial septal defect. The right atrium is slightly more compliant than the left atrium, so shunting occurs left to right, and there is a small amount of shunting. This is an example of a ventricular septal defect, which the shunting depends on the size of the defect itself and the pressure differential between the left ventricle and the right ventricle, and because the left ventricle is more pressurized than the right ventricle, shunting occurs left to right through it, with pulmonary overcirculation occurring. This is an example of an atrioventricular canal defect. It's most common congenital heart disease defect in children with trisomy 21, but it can also be seen in children with normal karyotypes. And unlike ventricular septal defects, shunting occurs primarily during diastole, and because of this, blood preferentially empties into the RV as compared to the LV. But it has a very similar pathophysiology to ventricular septal defects. So what is the pathophysiology of left to right shunts? There's a significant proportion of left-sided output is shunted to the right ventricle away from the vital organs. In order to maintain adequate systemic cardiac output and oxygen delivery, the left ventricular end diastolic volume increases. The greater degree of the left to right shunting, the greater the increase in left ventricular end diastolic volume and total left ventricular output. So why is this child presenting now? The pulmonary vascular resistance gradually dropped, reaching its nadir at about 2 to 3 months of age, which would be approximately 50% of newborn values. And as the PVR decreases and right ventricular compliance increases, the pressure differential between the left ventricle and right ventricle increases, leading to an increase in shunting and a greater pulmonary blood flow compared to systemic blood flow, or QP to QS. Also at this age, about 2 to 3 months of age, physiologic anemia of infancy is also reaching its nadir. So how to diagnose these? History, physical exam, chest x-ray, EKGs or ECGs, and serum BNPs can be helpful. So the history will most likely reveal failure to thrive in more than 50% of the patients. They will have decreased weight gain but may have normal height. And then a careful feeding history often reveals abnormalities. Less than 3, the patient's not able to take more than 3 ounces of formula per feed, or feeding times are greater than 40 minutes at a time. On physical, you'll often get hepatomegaly, which is suspicious for congestive heart failure. Because there's pulmonary overcirculation and pulmonary edema, the child will often be tachypnic, and your liver edge is usually greater than 2.5 centimeters below the costal margin. You may have a wide pulse pressure, which would be suspicious for increased diastolic runoff, and these would be present in lesions such as aortopulmonary window, a large patent ductus arteriosus, or truncus arteriosus, or arteriovenous fistula. Here's cardiac murmur, 6 cardinal signs that may be present. And how do you manage these patients? Assess the airway and breathing. If they're protecting their airway and they're not tiring out, then move on to the circulation part. But tachypnea is often acceptable in these patients. If the work of breathing is excessive, then I would consider careful endotracheal intubation to reduce metabolic demand on your LV and afterload. So how do you stabilize the circulation? If the blood pressure, mental status, and pulses are acceptable, start with diuresis. Patients with congestive heart failure have excessive preload, and diuresis will decrease your left ventricular end diastolic volume. After that, you can consider afterload reduction with ACE inhibitors, or if you're going to use an infusion, milrinone would be a good drug to start with. digoxin may also play a role. If the patient is hypotensive, has altered mental status, weak pulses, and prolonged cap refill, start vasoactive medications with a list of acceptable vasoactive medications just below. And all of these drugs have calcium-dependent mechanisms, so so an ionized calcium that is low should be corrected. Goal-directed therapy includes a capillary refill less than 2 seconds, the extremities warming up, improving pulses, heart rate that improves, good urine output. A Foley may need to be necessary for this, a normal lactate, and mixed venous saturation greater than 70%. I'm running out of time here, so this last case is just a 2-month-old that presents to your clinic with fussiness and poor feeding that came on all of a sudden. You can see that the main vital sign out of range here is 260. I would obtain an EKG. If you're unable to obtain an EKG in your office, I would send the child to an emergency department to obtain an EKG. And you can see here that the child is in some form of supraventricular tachycardia and that we are not able to identify. This is a nice slide on treatment of SVT. First needs to be classified as stable versus unstable. If it is unstable, then you will use cardioversion to cardiovert the child, somewhere between 0.5 to 2 joules per kilo. And remember to synchronize in cardioversion before you actually discharge the electricity. If the child is stable, you can use maneuvers such as vagal maneuvers, ice to the face, Valsalva maneuvers depending on the age of the child, or drugs such as adenosine to try to break the SVT. But remember to get an EKG before, during, and after, as it'll help the cardiologist to make the diagnosis of the specific type of SVT. This is just the for stable SVT. This is the dose, 0.1 milligrams per kilogram of adenosine to administer. If you would like to start infusions, you could start esmolol, procainamide, or amiodarone. Depending on the SVT type, I would definitely have a cardiologist be involved in this part. And remember, if it was me, I would actually start at 1 to 2 milligram per kilo bolus and bolus it very slowly for amiodarone because it has negative inotropic properties and can cause cardiovascular collapse. To wrap up, here are my take-home points. Diagnosis of an infant with congenital heart disease is difficult, and stabilizing them is even harder. A good physical exam is key. Don't just keep giving fluid, especially if it's not helping. And one way to check that is to check the liver. Have a low threshold for intubation for these patients, but make sure to do it purposefully and carefully. And there are really no contraindications to prostaglandin infusion. Thank you for allowing me again to present at your conference. I very much appreciate it. My email is just below. Feel free to email me if you have any questions or any follow-up. Thank you very much.